Hello guys, in this edition of the Amalgam revision videos, we'll be discussing about study models and model analysis. It's been a pretty consistent topic with regard to the entrance exams. Few questions have come on and off. So let's discuss the important points and whatever you need to know from this topic. So going on to the parts of a study model. Generally, if this is the study model that you can see in front of you, this part is called the artistic part, and this part, which is comprising of the anatomy, the tooth and the gingiva, is the artistic part. So the ratio of the anatomic to artistic part is 3:1. This question has been asked, I think, in the recent NEET exam. So if they ask you what a study model should have, an anatomic to artistic part ratio is 3:1. So please remember this ratio. There have been few inconsistencies with I think few books, but this 3:1 seems to be the correct. Some books do say 2:3, but according to us, we have done few researches from the textbooks, and I think it's 3:1. You can go with 3:1. So they might ask you a picture question regarding this. What are these? These are something called as base formers. Initially, they were making a round base and trimming these bases in different angles and heights. But nowadays, pre-made bases with these set sizes are available, and these are called base formers. And you just have to place the cast on these for basing. So these are called base formers. It can be an image question. So next that they may ask is the values that surround the models. One, the size of the artistic part is 13 millimeters, and the anatomic part is 1/3. The artistic part is 2/3 per cast, and the whole length of this model, both upper and lower, will be 70 mm, and these are few questions that could be asked, these values 70 mm. And the angles, you can see this in the front near the canine region is 30 degrees, and near the molar is 130 to 135 degrees. Generally, this kind of trimming the cast per proper angles is not practiced nowadays, or everybody uses base formers. It's a pretty outdated one, but sometimes they do ask you such questions. So please make a note of them in your notes, and you can revise them when you're doing your final revision. Next is something that they ask about nathostatic models. They can ask about this type of models, regarding who gave this nathostatic models. It was given by Paul Simon. Paul Simon is the one who gave the canine-based classification of malocclusion. He gave the Simon plane and all that. So in classification of malocclusion, you would be able to identify Paul Simon. He gave the nathostatic models. They are nothing but these models are trimmed and they are corresponding to the FH plane. So he said that the casts should not just be articulated just like that. They should be adapted to the FH plane. So that is what nathostatic models are. So you just need to know what they are, what plane is used, and who gave them. Next is Kessling's diagnostic setup. Kessling's diagnostic setup was initially developed by, you can see the name Kessling. So what they did was, they made a cast, they sectioned all the tooth separately, like you can see with this saw. They used to grind the teeth and they take out bits of teeth like this. So you get like a prosthodontic teeth setting, but you just do it on the patient's original teeth, that is the cast teeth. So you trim off this excess part and adapt it according to how you want it. Say the patient has a crowding, you want to relieve the crowding and see if the treatment would work if you remove 2 teeth, or if there is going to be any space left. So it's just a diagnostic setup to check if your treatment plan would work. So in such cases, you can adapt it with wax, just like your teeth setting, prosto teeth setting, and set the teeth. You can see the wax here, and you can set the teeth here. So this was given by Kessling's diagnostic setup. It is generally used as a pre-treatment workup, so that to check in some complicated cases that if the extraction space can be managed or not. The question that was asked regarding this diagnostic setup was regarding clear aligners. Clear aligners are based on Kessling's diagnostic setup. What they do in 3D printing is what we do manually in Kessling's diagnostic setup. There are few companies that manually do this Kessling setup. They move the teeth 1 mm every visit and then make a thermoform tray. So clear aligners were initially based on Kessling's diagnostic setup. This was one question that was asked, so you can note it down. Next, going into the model analysis, there are two types of analysis, as you all know: permanent dentition analysis and mixed dentition analysis. Permanent dentition analysis are generally done to see if the space that is required for the patient is available or not. Mixed dentition analysis is if the space in the arch is enough for the erupting tooth or not, or to check how big the erupting tooth is. That's all. So first we go into the caries and arch perimeter analysis. You need to remember caries is done in the lower arch perimeter analysis is done in the upper arch. This could also be a potential MCQ. So caries and arch perimeter analysis to check the arch length discrepancy. So total tooth material is calculated. How do they calculate? Mesiodistal width of all the tooth is measured using a brass wire, and then the arch length is total tooth material is measured with a ruler. Arch length is measured with a brass wire, and then both are subtracted. If there is excess space, then the arch length would be higher than the tooth material. If there is crowding, the arch length will be lesser. Based on how much less the arch length is, you make a small inference. This is if the space discrepancy, the space that you need to make for the patient is between 0 to 2.5 mm, then you need to do something called as proximal stripping or interproximal reduction. So you reduce the tooth sizes and then you create space. If the space is 0 to 2.5 mm. If the space is between 2.5 to 5 mm, then second premolars are extracted to accommodate. If the spaces are more than 5 mm, then first premolar extraction is done. Generally, they might give you the space. Say if the patient has only this much amount of space available, what treatment will you do according to caries and arch perimeter analysis? Then you need to remember the inference. Arch length tooth material discrepancy is done by caries and arch perimeter analysis. Caries analysis is done on the lower arch perimeter is done on the upper arch. Next comes Ashley-Howe's analysis. I'll be giving just an overview of all these analysis. What you need to know in this model analysis just to crack the exam. You can read about these analysis in detail from your textbooks. There are plenty of notes that are available in the Amalgam app. So you can make use of them to read in detail about these analysis. So Ashley-Howe's analysis just tells you if you need to expand the arch or not. You have a patient coming in with a bit of crowding. Will expanding the patient's arch help you in relieving getting space? That's all you're going to find out. So you're going to measure something called as the total tooth material. Mesiodistal width of all the teeth are added up and the sum will give you the total tooth material. Then you're going to do find something called as the premolar diameter and the premolar basal arch width. According to this analysis, they say that if the premolar basal arch width is wide enough to accommodate all the teeth, you can expand the arch so that a tooth will be within the arch. So how do you measure the premolar basal arch width? 8 mm from the tip of the canine. You measure from one canine to the other, or from the canine fossa to canine fossa you measure anteriorly. So that will give you the premolar basal arch width. So if you are going to calculate something called as premolar basal arch width percentage, which is the premolar basal arch width into 100 divided by the total tooth material. This you need not remember all these formulas much, but you need to remember the inference and you need to remember what value and why is it measured. So inference, if you get the percentage to be 37% or less, then it means that the premolar basal arch width is already wide, you cannot expand anymore, so you need to extract the teeth to create space. So if the premolar basal arch width is 37 to 44%, which means that you can expand it to a bit but not so much. So it's a borderline case. Based on the clinical situation, you need to take a call. Next is 44% or more, which means the arch is slightly constricted. you can expand it, and you can gain space. So the treatment plan will be a non-extraction line of treatment plan. 37% and less is extraction, 44% or more is non-extraction. You need to remember this inference. They might ask you like a scenario based question which mentioning these values and to tell you what kind of treatment plan you will go with. So you have to remember these inference. Next is Pons analysis. Pons analysis, you measure the maxillary incisors and establish the width of the arch at premolar and molar region. So what you do is you measure the four maxillary incisors, and you're going to measure the width at premolar and molar region. So what you need is sum of incisors. You need to measure the mesodistal width of all these incisors and take a sum. Then is measured premolar value, measured molar value, calculated premolar value, and calculated molar value. Sorry, it's a mistake. So measured premolar value is measure the distance between the two premolars, and molar value between the mesial pits of the two molars. You measure, you take a value. So you calculate the calculated premolar value. Sum of incisors into 100 by 80. Calculated molar value, sum of incisors into 100 by 64. You need not remember the formula much. But when the measured value is lesser than the calculated value, it means that the teeth are at a constricted way than the arch. So you can expand the arch. That's what it means. So Pons analysis is not a very important analysis. You just need to know that upper anteriors are used as a guide to determine whether expansion is required or not. In next Linderhardt analysis, it's the same procedure, but just this the formula are slightly different. However, in Bolton's analysis, you take the lower incisors width, 4 lower incisor width, to calculate the Bolton's discrepancy, which we'll come to. With Bolton analysis, one MCQ is that it's called the 7th key of Andrew's 6 keys of occlusion. Bolton's analysis is considered to be the 7th key. So what you need to know about this analysis: the fit of tooth, both the arches, total tooth material, arch length was by Caries, whether the arch can be expanded or not, which was done by Ashley Hose and Pons and Linderhardt. Bolton's analysis, they kind of give you whether there is a tooth material excess or tooth material deficiency. If the maxilla and the mandibular teeth are correctly fitting, if the maxillary teeth are larger, then it means that it needs more space. So there might be proclination, there might be more crowding. So with Bolton's analysis, you can correctly identify if there is any size discrepancies. So what you need in this analysis: sum of maxillary 12, you need to sum all the 12 teeth from the molar to molar, sum of mandibular 12, molar to molar, sum of maxillary 6, canine to canine, sum of mandibular 6, you take a value. So you substitute, you measure something called as overall ratio and anterior ratio. Overall ratio, you check if all the maxillary teeth sizes and all the mandibular teeth sizes are proportional to each other. Anterior ratio is that if the anterior teeth alone are proportional to each other. So always mandibular first, sum of mandibular 12 by sum of maxillary 12 into 100. Anterior ratio is the same, sum of mandibular 6 by sum of maxillary 6 into 100. You just need to remember this important value. 91.3% is the overall ratio. If the overall ratio is greater than 91.3%, it means that there is a maxillary overall excess. That means the maxillary teeth are slightly larger than the mandibular teeth. If the anterior ratio is greater than 77.2%, then it means that the maxillary anterior excess, which means that the maxillary anteriors alone are slightly larger than the mandibular teeth. If it's the opposite, if the ratio that comes is lesser than 91.3, then it means that the mandibular teeth is at excess. That is, the mandibular teeth is larger than the maxillary teeth. This is what the Bolton's analysis is about. So Bolton's analysis, remember the values and remember the interpretation. Next is something they had asked in AIIMS exam about something called as a Peck and Peck analysis. Peck and Peck analysis is an analysis for lower incisor teeth. So just to check whether they are wider, excessively, mesiodistally. So the ratio between the faciolingual dimension of the mandibular incisor and the mesiodistal dimension should be 1:1 for lower incisors. If the mesiodistal dimension is more, then it means that the lower incisors will be crowded. So you need to do interproximal stripping. So this is what Peck and Peck ratio. They might ask you a question saying that Peck and Peck ratio, which analysis is used to just for lower incisors, which is Peck and Peck. It was given by Sheldon and Harvey Peck. So this question was once asked in an AIIMS exam. So please make a note which analysis for lower incisors alone. Next is Korkos analysis. It's a study model analysis that would reveal anterior posterior malpositioning of the incisors in maxillary and mandibular arches. So that is the Korkos analysis. Just you need to remember the names. Next we move on to the mixed dentition analysis. So these are the mixed dentition analysis. They will ask you questions regarding which of the following is a radiographic analysis, which of the following is a non-radiographic mixed dentition analysis. So here is the table. Radiographic analysis is Nance and Hakaba analysis. Non-radiographic analysis is Moyers, Tanaka Johnson, and Ballard and Willi analysis. The combination of both radiographs and prediction charts is Staley-Kerber analysis and Hickson-Oldfather analysis. So we'll just discuss Moyers mixed dentition analysis. Moyers mixed dentition analysis takes use of the lower incisors. So based on the first teeth to erupt is the lower incisor, and they generally do not have any size discrepancies, just like maxillary anterior teeth. Maxillary anteriors usually has peg-shaped laterals and all that. So, but mandibular anterior teeth are generally uniform in size, so they have taken the lower incisors. So based on the width of the lower incisors, they are going to predict how big the canines and the premolars are going to be. So how do they predict? They do something called as probability charts. Probability charts is that they have recorded so many people's mesiodistal width of the lower incisors and the premolars. So they have made like a statistical table. So the 75th percentile is taken generally by preferred, because to rule out any abnormal shapes, to have a centered value. They have taken the 75th percentile probability charts and match it with the. So when a patient comes, you measure the size of the lower incisors. In the charts, you see the table, and you will get your measured combined width of the premolars and canines. That's it. That's the Moyers mixed dentition analysis. Probability chart is what you have to remember. Then came Tanaka Johnson's analysis. This is similar to Moyers. You use prediction tables, but they also give you a formula. So predicted width of maxillary, canine and premolar, it's the same sum of mandibular incisors plus 11/2. Sum of mandibular incisors plus 10.5/2 will give you mandibular, canine and premolar values, and 11/2 will give you maxillary, canine and premolar. And just there is a formula involved. That's the Tanaka Johnson analysis, non-radiographic analysis. So to sum of everything, permanent dentition analysis, they might ask you an MCQ, which of the following is a mixed dentition analysis, which of the following is a permanent dentition analysis. So you need to remember these names. Pond's index, this is based on maxillary incisors. They measure the width of the incisors and find out if the arch can be expanded or not. Korkos analysis, anterior posterior displacement can be found out. Linderhart and Pond's are the same. Arch perimeter analysis and Carey's analysis, arch length, tooth material discrepancy. Bolton's analysis, total tooth material discrepancy. Ashley-House, to expand or not. Peck and Peck index, only for the lower anteriors. So these are the permanent dentition analysis. Then we go to mixed dentition. Hokaba's analysis is radiographic analysis. Hickson-Oldfather, both radiographic and non-radiographic. Moyers mixed dentition analysis, non-radiographic analysis. Nance analysis is a radiographic analysis. So these are the different analysis, and there is one picture question I want to show you. This is something called as a symmetrograph of burn claw. What they do is there can be something called as pitch, roll and yaw. You will have a separate video for that in the amalgam video bank. So what they do is, yaw is something called as a midline shift. There is a shift in the there's a twist along the midline. So what happens is the patient will be presenting to you with a midline shift. The symmetry of the arch is changed. So initially how they were measuring is they were using something called as a symmetrograph. This symmetrograph is like a grid. It's like a graph paper, a grid placed on a plastic sheet. So they place the cast on this grid and check whether the midline is coinciding with the normally, and each arches are symmetrical or not. So just to check that, there's something called a symmetrograph of Burnclaw. This may be asked as a picture based question, so I've just added a picture. So that's it for today's session, and more videos will be available. You can check out the Amalgam video bank. Thank you.